Hi everyone, and welcome to the premiere edition of the Pharm Easy Tutor channel. My name is Ken Eto, and today I'll be talking about antibiotic therapy. Because it's such a broad topic, it'll be covered in 4 parts. Now, antibiotics are used in virtually all disease states, so it's a challenge to cover everything. My goal is to provide concise information in an organized way. Part 1 of the antibiotic series will last about 30 minutes, so if you'd like, you can take a pause about halfway through and then return to watch the rest of the 15 minutes. I'll try to make it as interesting as possible so that the material will move along fairly quickly. Make sure to take notes and listen carefully, as there might be surprise quizzes along the way. I hope you'll enjoy this series of tutorials. Antibiotics Made Simple is the title of this 4-part lecture series. Now, antibiotic therapy is a huge topic which covers a vast scope of material. So how can we successfully achieve this learning task? The key is to condense a large amount of information into something that's practical to use, and also to organize the material so that it can be retrieved easily in the future. Now, one note before we begin is that the names of the organisms are usually italicized in the literature. In this presentation, I will not be italicizing these names. Part 1 will cover some basics, including microbiology principles, and will also introduce you to Staph aureus. So let's go over all of the parts of this lecture series. In Part 1, we will discuss the basics and Staph aureus. Part 2, we will cover the rest of the gram-positive organisms. In Part 3, we will go over anaerobes and atypicals. And in Part 4, we'll finish off by discussing the gram-negative organisms. Now, in the future, I plan on presenting lectures on antibiotic-related topics, which include treatment of multidrug-resistant organisms, Clostridioides difficile, or C. diff, and antibiotic stewardship principles. This slide compiles a comprehensive list of the names of the most common bacteria that we will be learning about. The table organizes them into key groups. The 3 major categories are gram-positive cocci, anaerobes, and gram-negative bacilli. There are also 3 smaller groups at the bottom that are important to talk about, but aren't in the 3 major groups. Please take a moment to familiarize yourself with the content of this table, as it will serve as a roadmap for these lectures. I also created a complete list of currently available IV antibiotics. They are organized by class for your reference. We will talk about each of these groups and link them with their respective bacteria as we move along in the lecture series. As before, please take a moment to review this table. I also included some of the newer agents, including the beta-lactam/beta-lactamase inhibitor combinations. We will not be covering this group of antibiotics in this lecture, but will be included in a future lecture on multidrug-resistant organisms. You may be thinking, how can I possibly match up all of these organisms with their respective antibiotics that are used to treat them? Well, it is very difficult. And in order to avoid getting mixed up, it's very important to organize your thoughts into the 3 key categories that we previously discussed: the gram-positives, the anaerobes, and the gram-negatives. If you link each one of these key categories with the antibiotics coverage, then it helps organize your thoughts. So please keep this in mind. It's very important to organize your thoughts. Now, groups not covered in this lecture series are fungi, viruses, and parasites. It's also important to remember to not get discouraged. There's a lot of material, and it can be overwhelming at first. But it will take time, and you'll need to work at it. Remember that learning is not an osmotic process. You need to take notes and regularly study the material. We'll take it a step at a time, and before you know it, you'll improve your knowledge of using antibiotics. Now, a little microbiology before we begin. What is a gram stain? Well, a gram stain is a staining process used in microbiology, and it's almost always the first test performed for identification of bacteria. It helps us identify the type of bacteria earlier, before the time it takes to wait for the culture results to be reported. Have you ever wondered how the gram stain got its name? Well, here's the man, Hans Christian Gram, who is the inventor of the gram stain. He's a Danish physician who in 1884 discovered the gram staining process working in Berlin. This was a groundbreaking technique used to identify and classify bacteria. Now, the gram stain not only improved identifying bacteria, but also distinguished them between two major classes. It was able to differentiate between gram-positive and gram-negative bacteria. So this discovery not only made bacteria more visible under a microscope, but it also played a major role in classifying bacteria. So how does the gram staining process work? Well, first a smear of bacterial cells are placed on a slide. Then it's treated with a primary stain of crystal violet, and then counterstained with a Ceftaroline dye. Under a microscope, this is viewed, and bacteria that look purple or brown are termed gram-positive. Bacteria that become colored red or pink are termed gram-negative. So the gram reaction identifies differences in the composition of the bacterial cell wall. Here's a diagram showing the difference between gram-positive and gram-negative bacterial cells. And you can see the gram-positive bacteria have a very thick peptidoglycan cell wall, where the gram-negative bacteria has a very small cell wall. The other difference that you can see is that the gram-negative organism has a thick outer membrane, and the gram-positive organism does not have this. And this will be important when we discuss this in a minute. So bacteria with a thick cell wall does retain the crystal violet stain that we talked about in the last slide and turns it purple in color. So we can see that these are gram-positive organisms, whereas the gram-negative organisms has a very thin cell wall which is not able to retain the crystal violet stain. And when they use the Ceftaroline counterstain, it stains the cells red, and so you know that these cells are gram-negative organisms. So let's review the differences between gram-positive and gram-negative bacteria. As far as structure, the gram-positive bacteria has a thick peptidoglycan cell wall, whereas the gram-negative bacteria has a thin cell wall. The gram-positive bacteria does not have an outer lipid membrane made up of lipopolysaccharide, whereas the gram-negative bacteria does have an outer lipid membrane. And as we mentioned in the slide before, gram-positive bacteria stain purple and gram-negative bacteria stain pink. As far as characteristics of the bacteria, gram-positives are more susceptible to antibiotics because the cell wall of these bacteria are exposed without that outer lipid membrane, and so it will absorb antibiotics. It does produce exotoxins. Gram-negative bacteria, on the other hand, are more resistant to antibiotics because it does have that large glycolipid complex of the lipopolysaccharide that protects it from antibiotics and harmful substances. Gram-negative bacteria produce exotoxins as well as producing endotoxins, which are substances that can cause inflammation and sepsis if it enters the blood. So gram-negative bacteria are much more resistant to antibiotics and are more dangerous to the human body. Now, what about anaerobes? Are they gram-positive or gram-negative? Yes, they can be either one, but we need to keep them in their own special separate category. So again, that is the third major class of antibiotics that we're going to be talking about. What about atypicals? Well, atypicals lack that peptidoglycan cell wall, which normally holds the stain. So when they do a gram stain, it's not detectable. They remain colorless, and that's why they're called atypical. And we're going to also keep them in their own special separate category. So why is it so important to do a gram stain? Well, knowing whether the organism is either gram-positive or gram-negative makes an important difference on which antibiotic we select to appropriately treat the infection. So now we're going to start talking about different types of bacteria and their treatments. In the first group, we're going to be talking about are the gram-positive organisms. Gram-positive organisms as well as gram-negative organisms has a subcategory called cocci and bacilli. So what's the difference between these two? Well, let's talk about the gram-positive cocci, which form the majority of the group. Staphylococci appear as clusters or grape-like structure. You can see the picture of the staph all clustered together. Now this is because when cell division occurs in staph, it divides along multiple axes, and this generates these grape-like clusters of cells. Streptococci, on the other hand, appears as pairs or in chains. So you can see the diplococci and streptococci there. And so in contrast, when cell division occurs in streptococci, they occur on a single axis, not a multiple axis. So they grow and form pairs or chains, which can either be bent or twisted. The other group are gram-positive bacilli, and bacilli appear as rods, so their structure are more long and elongated, not circular. And this group forms the smaller of the two subgroups of gram-positive organisms. So let's talk about the first group of gram-positive organisms named Staph aureus. And Staph aureus is the most virulent of all the gram-positive organisms. And there's two types of Staph aureus. There's MSSA, which is methicillin-sensitive Staph aureus, and then there's MRSA, which is methicillin-resistant Staph aureus, which can either be hospital-acquired or community-acquired. Now, Staph aureus is primarily a skin surface organism. It's found on the skin, which causes skin infections such as cellulitis, abscesses, decubiti, surgical wound infections, and line sepsis. So if a patient has any of these types of infections, you're going to suspect Staph aureus. However, in hospitalized patients, Staph aureus can somehow get into the body and be responsible for many other types of infections. It can get into the blood and cause sepsis or toxic shock syndrome in the lung, pneumonia, in the heart, endocarditis, in the brain, meningitis, in joints, osteomyelitis. It can get into the colon and gut and cause intra-abdominal infection, and it can cause urinary tract infections. So another bit of history to talk about. Who is this man and why is he so important when we're talking about the treatment of Staph aureus? Well, if you guessed Sir Alexander Fleming, you are correct. He is the one who discovered penicillin in 1928. Fleming was a Scottish physician-scientist who was working on a series of experiments which involved Staphylococcus aureus. He did this in 1928. When he came back to his laboratory from a family vacation, he found an uncovered petri dish of Staphylococcus sitting near an open window, and he found that it was contaminated with mold. What he noticed was that there were some bacterial colonies that were next to the mold, and these were dying, whereas other staph colonies that were farther away looked normal. So he called this mold juice, which contained an antibacterial substance that he later isolated and identified it as being from the genus Penicillium, later naming it penicillin. So how effective was penicillin? For gram-positives, it was very effective. He found that it was effective against all gram-positive pathogens that he tested it against: scarlet fever, pneumonia, gonorrhea, meningitis, and diphtheria. So this was a huge breakthrough. On the other hand, Fleming was searching for a cure for typhoid fever. Unfortunately, typhoid was gram-negative, and so penicillin was not effective against it. So what happened to penicillin? Well, over the years, with greater exposure to penicillin, the Staph aureus bacteria slowly learned to develop mechanisms of resistance to penicillin. The next slide shows how Staph aureus transformed itself from being sensitive to penicillin into methicillin-resistant Staph aureus. Now, initially, Staph aureus was susceptible to penicillin G. However, with greater exposure to penicillin, the Staph aureus bacteria developed resistance by producing the enzyme penicillinase that destroyed penicillin. So it became smarter and more resistant. Scientists then developed semi-synthetic penicillins, one example called methicillin, with a branch on its structure to block the enzyme. So this was effective against MSSA. Now, methicillin did cause interstitial nephritis in patients, and so other drugs were developed, oxacillin and nafcillin, and they were used. However, the MSSA bacteria developed resistance to these semi-synthetic penicillins. So this is how MRSA evolved. MRSA infections now require the use of vancomycin. The incidence of MRSA is now about 55%. And so now there's future concerns for development of vancomycin intermediate or vanco-resistant Staph aureus because of overuse of vancomycin. Let's move on now and talk about the treatment of Staph aureus infections. Let's first talk about the treatment of MSSA, or methicillin-sensitive Staph aureus infections. And the treatment of choice for MSSA infections are the semi-synthetic penicillins, oxacillin, or nafcillin, given in a dose of 2 grams every 4 hours. These semi-synthetic penicillins are superior clinically over the cephalosporins or vancomycin. However, if you have a penicillin allergy, you would be using high-dose ceftaroline, 2 grams every 8 hours. And if you have a severe beta-lactam allergy, then you can use either vancomycin or daptomycin. Now, there have been recent reports of about 10 to 30% of patients treated with ceftaroline who had worse outcomes when they used ceftaroline for MSSA infections. And this is due to what's called an inoculum effect. And you can see in the footnote what the effect is. Basically, the antibiotic works against highly dense bacterial populations, lending for a slightly worse outcome and inefficiencies. Now, this can happen with ceftaroline and also other cephalosporins. And it can also happen with unicin or zosyn. So again, these antibiotics are probably not the ideal antibiotics to use to treat MSSA. You want to stick with using the semi-synthetic penicillins as much as possible. Now let's move on and talk about the treatment of MRSA. And this discussion involves quite a few more antibiotic choices that are available to use. And what we'll try to do is to prioritize them in terms of which antibiotic to use in certain clinical situations. Now, as you know, vancomycin is the workhorse antibiotic for initial treatment of MRSA infections, whether they're suspected or documented. Now, recent IDSA guidelines recommend looking at the AUC-MIC ratio, and ideally the target goal for that is 400 to 600 for optimal effectiveness and low nephrotoxicity. Guidelines also recommend looking at utilizing Bayesian kinetic modeling. Adverse reactions to vancomycin are redneck syndrome due to rapid infusion, and nephrotoxicity, which is associated with trough levels of 15 to 20 micrograms per mil. Now we'll talk a little bit more about vancomycin dosing in a separate lecture series on pharmacokinetics. One other comment about vancomycin is that we do need to be more aggressive when we're treating more severe infections such as endocarditis, osteo, meningitis, or pneumonia due to poor penetration of the drug. Now, the second tier after vancomycin includes 3 antibiotics that I would recommend to use in different clinical situations. The first drug is linezolid or Zyvox, and this antibiotic has very good lung penetration compared to vancomycin. So for pneumonia, MRSA infections of the lung, this is the preferred antibiotic to use. Its main adverse drug reaction is myelosuppression, neutropenia, thrombocytopenia, and anemia. So that's something that you'll need to monitor with any patient that's on linezolid. There's also some drug interactions that are associated with concomitant use of catecholamines and SSRIs, SNRIs. The dose is 600 milligrams twice a day, and one of the advantages is that it can be given both IV and oral with good absorption. Now, linezolid, as you'll see later on, it can be used for VRE or vancomycin-resistant enterococcus. The price has come down significantly since it went generic, and so it is affordable antibiotic to use and recommend. The second antibiotic that's used for MRSA is daptomycin and cubicin. And this is an excellent antibiotic to use for bacteremia due to MRSA, so blood infections. Now, it's not recommended for use in pneumonia because lung surfactants inactivate the drug, but it is approved for Staph aureus bacteremia and also right-sided endocarditis, and also it's good for skin and skin structure infections. Now, daptomycin uses concentration-dependent killing, which means you'll need to give a higher dose at a less frequent interval. And in renal failure, instead of reducing the dose, you want to keep the same dose but extend the dosing interval. The main adverse drug reaction is increased CPK and muscle or possible muscle damage. And one of the good things about daptomycin is that you can give it slow IV push instead of as an IV piggyback, and this can be handy in home health where you can give it a slow IV push over 2 minutes. The recommended dose is 4 to 6 milligram per kilogram every 24 hours, but it has been used at higher doses of 8 to 10 milligram per kilogram for left-sided endocarditis or even for bacteremia, but this is a non-FDA approved dose. It is generic, and it has come down considerably in price, and so it is affordable to use for infections. The third choice of antibiotics that I want to talk about is tigecycline or Tigesil, and this is a great drug to use for skin infections, primarily mixed skin infections where you have both MRSA and other types of bacteria affecting the skin. It is a tetracycline, and it's not for pediatric use, and it's a chemical analog of minocycline. It is bacteriostatic, it's not cytal, and the expanded spectrum of tigecycline is that it does hit anaerobes and all gram-negatives except for what I call the 3 Ps, Proteus, Providencia, and Pseudomonas. So we'll go over this a little bit more in the gram-negative discussion. The main adverse drug reaction is nausea, which happens in about a fourth of patients, and phlebitis, as all tetracyclines can cause when given IV. The dosage is a 100 milligram loading dose and then 50 milligrams every 12 hours. And it is generic, and so it has become more affordable than it was when it was a trade drug. So these are the second-tier antibiotics to consider using for MRSA after vancomycin, either after vancomycin failed or if you cannot give vancomycin. And each one has a specific role. Linezolid is very good for pneumonias, daptomycin for blood infections, and tigecycline should be recommended for skin or wound infections involving MRSA. Now, another antibiotic that we can use against MRSA is named dalbavancin or Dalvance. And this antibiotic is in a special category which I call the single-dose alternative, which means that you can give the entire dose regimen as a single dose of 1,500 milligrams, and it will cover the entire treatment regimen. It's only indicated for acute skin and skin structure infections. But if you're dealing with a patient that's going to be visiting, let's say, the emergency room that has a skin infection, and you don't think that that patient is going to be compliant with their oral antibiotics as an outpatient, this might be a good choice to think about. It is given over 30 minutes, which is great for emergency room use. Now, the antibiotic is a lipoglycopeptide that's similar to vancomycin. It's long-acting and it has an extremely long half-life of 346 hours. We do need to reduce the dose if the patient has a creatinine clearance of less than 30. The drug is expensive, but you can take advantage possibly of the 340B pricing if the antibiotic is given as an outpatient. Now I want to talk a little bit about third-tier antibiotics that can be used to treat MRSA. The first one is called Ceftaroline or Teflaro, and this is the first cephalosporin that has MRSA coverage, and so it's considered fifth-generation cephalosporin. The main use for Ceftaroline has to be when you're talking about MRSA cases that are resistant to treat. And so down the line, if daptomycin or vancomycin is ineffective, quite often they'll turn to Ceftaroline to use it in combination with one of those two. It also has some expanded spectrum against gram-negatives, but is not a good Pseudomonas drug or even a good anaerobic drug. The dose we use is 400 to 600 milligrams every 12 hours. Now, the reason why it's not a fairly commonly used MRSA antibiotic is that it is costly. It's over $400 per day. So again, we reserve it for uses where there are resistant MRSA infections going on. Another fairly new drug that came on the market is named Delafloxacin or Baxdela. And I call it the superquinolone just because it does have coverage against certain key organisms that are out there. However, it may not be super overall because it does have some deficiencies in terms of gram-negative coverage. But it does have MRSA coverage. It does hit Enterococcus faecalis, which we'll learn later that it is a more difficult to treat bacteria. And it does have Pseudomonas aeruginosa coverage. But again, as I mentioned, it does have less gram-negative coverage than ciprofloxacin. It's indicated for use in adults with skin and skin structure infections. And it can be given both IV and orally with a different oral dose than the IV dose. And we need to reduce the dose if the creatinine clearance is less than 30 due to the vehicle that it's mixed with. Again, it may be too broad spectrum to practically use, but it is available as an alternative. Now, just a moment to talk a little bit about some rarely used antibiotics for MRSA. Tedizolid is a linezolid me-too drug. We hardly use it at all in clinical practice. It is expensive, and the advantage is that it can be given once a day. Aureus is similar to dalbavancin, but it does take 3 hours to infuse it, and it does have significant lab interactions, and so it does have its disadvantages, and so we tend not to use it. And telavancin did come on the market. It is a synthetic derivative of vancomycin, but because of its cost and possible nephrotoxicity, it's no longer used as much. Congratulations! You successfully completed part 1 of 4 parts. You're on your way to improving your antibiotic competency. And look what your learning already did to Mr. Bacterium. Thanks for tuning in to watch this episode of the Pharm Easy Tutor. I hope you learned something that you could use in practice or at school. There was a lot of material presented, and it does take time to study all the information. If you would like to continue to see more of these types of tutorials on YouTube and to stay informed when the latest material is available to view, please make sure to click on the subscribe button below. Stay tuned to the Pharm Easy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.